And I think that's one of the bigger questions that's going to come out of all this. With the paper that was published, they really put emphasis on having almost an allotted individual solely doing antiretroviral stewardship. And I think that's going to be a little bit difficult in most situations where antimicrobial stewardship as a whole is typically underdeveloped and sometimes even underfunded with FTEs. And I think that the best way to do it would be through a series of a couple different things. One being an accurate way to identify these patients, whether it be through alerts with ICD-9 or ICD-10 codes, or even medication-specific alerts, and that there's some sort of flag with a clinical decision support that lets you know that, hey, a patient is being ordered or prescribed this medication. The other thing I think is through education, which is the simplest but most difficult of all in the perspective of making sure that the pharmacy staff and also medical staff, whether it be interns, residents, or fellows, understands the importance of antiretroviral therapy, because there's a lot of individuals, a lot of prescribers who have some angst about, oh, it's an HIV medication, I'll just continue it and we're not going to press forward in terms of making sure that these patients are compliant and that we have it. And then lastly is formulary status. I think that's going to be one of the more difficult ones because these medications are expensive and they're not widely used and not used as much as, say, an antimicrobial agent, amoxicillin or cefazolin even for that matter. And so I think that we'll have to figure out what's the best way to transition these patients from the outpatient to the inpatient setting. But hopefully at least this gets the conversation started in terms of pressing forward and hopefully curbing some of these errors that we've seen in HIV-infected patients.